Hi, thanks for joining us. This is Josh Kling, the CEO of Newport Medical Solutions, Newport Med for short. In this session, we are going to be reviewing the new 2022 CPT code changes that are specific to neurosurgery. There's not many, but the few that there are specific one specific to spine surgery will impact revenue. So this will be short and sweet, but very important for you to listen in on. And so I'm going to jump in. The changes this year, we've narrowed this session down to just neurosurgery. So there's changes in the editorial. 405 might look like a lot, but as far as new CPT codes, it's not that crazy. I think we have maybe 4 or 5 that are specific to you neurosurgeons, and we will go through those. First, we're going to jump into these ICD-10 codes that look to be more specific than what has been used in the past. Neelima, you want to jump in? And I forgot to even introduce, we have Neelima and Brooke. They're both our coding experts, and they're going to be helping walk me through all these changes. So go ahead, Neelima.
There have been 6 new codes that have been added to describe traumatic brain compression with and without herniation. So we have 3 codes, initial, subsequent, and sequelae of traumatic brain compression without herniation, and then with herniation. And these codes, the initial encounters, have been added to the list of major comorbid conditions.
And I see below it says 2 new codes are listed as MCCs. Brooke, what is MCC?
Major complication or comorbidity.
Major comorbid condition, yep.
Okay, all right, great, thank you. Go ahead, Neelima. We reviewed this with our orthopedic session, but let's reiterate it for our neurosurgeons.
Sure, so in the spine area, we have some diagnosis codes newly added to depict non-radiographic axial spondyloarthritis of the different areas of the spine. And then we have low back pain, which is very frequently used by all of our spine surgeons, which who do back spine surgeries. Back pain used to be only coded using M54.5, which was a generalized back pain for everything. Now we have 2 codes, one to depict vertebrogenic back pain and one to depict other sources of back pain, like all of the myogenic causes of back pain. So, and most of our spine surgery, the fusions and all of the surgeries, we would use M54.51 to be specific.
And you mentioned earlier, we don't want to use M54.50, the unspecified code. And why is that?
Very notorious to cause denials are our unspecified codes. So we should avoid unspecified codes on any of our claims.
Great, okay. So go ahead, Neelima, and take over on these spine coding changes because they're pretty significant.
Right. So spine posterior fusion codes have changed a little bit. In fact, they've changed to cause a dip in reimbursement this year. With respect to posterolateral or posterior fusions, the codes till last year had the definition as per segment, versus now they're being defined as per interspace. So when we had a 3-level fusion like C2, C3, C4, we would have been able to code 3 segment level fusions. So 1 code for C2 and 2 add-on codes for C3 and C4. But now we are only able to code 1 code for C2, C3 into space and another code for C3, C4 into space. So we go down by 1 code. And Josh, you talked about the reimbursement for the add-on code was $250, right?
Yeah, approximately.
Yeah, so that's what we will go down on with each additional level of fusion.
Yeah, that's a bummer. It seems like the AMA is fighting against their physicians and doing what the carriers want them to do.
Mm-hmm. Yeah. And that was for posterior or posterolateral fusions. So when it comes to posterior interbody fusions, laminectomy when done with posterior interbody fusion, the documentation has to be very clear that laminectomy is just not a part of the fusion surgery, but it's being done for decompression. That documentation is important for us to tell the payers that it is medically necessary. Laminectomy was medically necessary in those patients. And it used to be, the codes used to be 63047 and 63048, 47 for the first level laminectomy and 63048 for add-on laminectomies. 63047 was a standalone code. Now with posterior interbody arthrodesis, we have two new codes, 63052, which is an add-on code to the primary fusion code. And for each additional segment, we have another add-on code, which is 63053. And both of these codes, especially the first code, 63052, pays much lesser than 63047, which we are going to talk about in the next slide.
Yeah, and so one question I have, Brooke, and maybe you can help me understand this. So this is an add-on code, but it's only for a laminectomy done with interbody fusion, correct?
Right.
And so if a surgeon does just a laminectomy, they still use the 63047.
Right. Yes, absolutely. If they're doing just the laminectomy, they would use the code they've always been using.
Okay, great. All right. So here's the reimbursement comparison, and it's not good news. Again, something that we're fighting for every penny that we can get for our clients, and this doesn't help our cause. So last year and every year before that I've been in the industry, which is 20 plus years, for a 3-level laminectomy, it would be 63047 and then 63048 times 2. We've used the general Medicare reimbursement for those. So in previous years, a 3-level laminectomy done with interbody fusion would have looked like a reimbursement of $980. Part of that is because that 63047 code is reduced to 50% because it's secondary. Now that they're considering it an add-on code, they've devalued that procedure down to $260. The RVUs have gone down significantly. So it's looking like on a 3-level laminectomy, previous years, $980, from 2022 on, $660. So we're looking at a decrease of about $320. We've also just included a 2-level just so that you can see the difference. So you're looking at about a $300 per surgical case. Neelima, you had mentioned earlier, and I think it's good to say, we're looking at a general Medicare rate. We kind of averaged it, but your different payer contracts may increase or decrease based on the percentage of Medicare or the RVU value that they're paying you at. So this is just a generalization. It's not a perfect number, but if you are our neurosurgery or orthopedic client, you are doing spine surgery, once we get actual payment on these, and we can show you EOBs from previous to EOBs this year, we can compare real-time information. We will be doing so with you. Neelima, you want to jump in on this?
Yes, so there's 2 new codes for thermal therapy to destroy intracranial lesions. 61736 for the first lesion, and for multiple lesions it's 61737. This is just a new code. These 2 are new codes that have been introduced for destruction of those lesions by laser interstitial thermal therapy.
So let me ask you this, Neelima. So I see that it says complex lesions on 61737. Is that a standalone code or is that an add-on code?
It's a standalone code. So when we have multiple lesions, we could use that. Or when we have complex lesions, which again has to be, those lesions have to be documented as complex for us to be able to use that code. It is a standalone code, Josh.
Okay. All right, great. Thank you. And so for any of you neurosurgeons that take call on a trauma team or for one of your facilities, we just want to update you on some clarification that the AMA has given And this is basically, if you have a nurse practitioner, another colleague within your group that might be doing rounds with you, this is just clarification on how you build the critical care services that are 99291 is up to 74 minutes. And go ahead, Neelima, I'll let you take over on what this is clarifying.
Yeah, so when two practitioners are seeing the patient on the same date of service in the ICU at two different time slots, the time can be added up to amount to reach the first 74 minutes to be able to report 99291 once. So 99291 cannot be reported more than once per patient per day per group. The remaining time can be reported using 99292 by the other physician who rendered care on the same day. But the second physician's time can be added to the first physician's time to reach the time criteria for 99291, and the additional time can then be reported using a 99292.
Great. Okay.
And split and shared services, this happens typically again between an NP or a PA and a physician. So when an NP or a PA is rounding on the patient and then calling a physician to update on the patient's status, reviewing labs, those are called split shared visits. The time that's spent together is counted only once. It won't be double counted. But all of the time it's not only time spent at the bedside, it's also time spent in reviewing labs, reviewing any imaging, talking to other providers, talking to the caregiver or the family. All of this time will be added. It's important to document who provided the most part of the care or decision-making part of the care, and that will be the person under whom the service will be billed. And for CMS, they're requiring us to add a modifier called FS for split or shared critical care services.
Great. Okay. And then we have some new codes for therapeutic remote monitoring. So Brooke or Neelima, if you want to jump in and go ahead and tell us about this.
Yeah, so remote therapeutic monitoring, just for the setup and education, and then the supply and monitoring thereafter are reported using 98975 through 977. And any interactive communication done during that period is reported using 98980 and 98981, which is an add-on code for additional time. For our orthopedic and spine providers who have been using these codes, we were using 99453 series of codes, which was more general, which was more monitoring blood pressures and pulse oxes and all that. And now I think we have a more relevant code, which is more specific to monitoring musculoskeletal system status. So we can switch from 99453 to 98975 for the patient education part and 98980 for the interactive portion.
Great. Okay. And this is the end. And Brooke, I'll let you summarize this.
Yeah, so Appendix P in the CPT book will just list all the CPTs that are included in telemedicine services. These codes listed on this slide are not new. They have been established for a while now, but they are recognized as telemedicine services. And throughout the CPT book, they will be represented by a star next to them. Again, they are not new. They're just now recognized as being used for telemedicine as well.
So it seems to me like this is kind of the AMA catching up with what CMS and kind of what the emergency orders were as far as during the ongoing pandemic, what has evolved into telehealth. But I see here 99291 is listed. Does that mean that all the other E&M services are not telemedicine?
No, they still are. It's just the addition of 99211 being recognized.
All right, great. Okay. Well, thank you both. That brings us to the conclusion. We just want to let you know, if you are our client, we are monitoring these and watching out for these. If you are not, then please make your billing team aware of these codes if they aren't already. And if you have any questions, client or not client, we're happy to help answer them. Just hit us up at coding@newportmed.com. Neelima, Brooke, and their teams will be happy to help you based on the specialty and the need and the question. If we do delay in a response, it's not because we didn't get it right away or we don't want to respond right away. It's primarily because when we respond, we want it to be accurate with real-time information that we know is spot on. So thank you very much for your time, and we hope to talk to you soon.
Thank you.
Thank you.